Hey guys, what's up? Welcome to your last week of lecture. All you have left for next week is a forum and a final exam. This week's lecture encompasses all of Chapter 32, so it may be split up into two separate parts because it probably is going to take a little longer than the others. Chapter 32 is all about administration of parenteral medications, meaning anything that goes through not the GI tract. Excuse me. Medical assistants are often responsible for the administration of parenteral medications. The most common form is injectables. In order to successfully perform this task, the medical assistant must be able to properly select the equipment, prepare the medication, find a suitable site, and administer the medication with the correct technique. Parenteral means pertaining to the outside of the intestines. When referring to parenteral medication, it means to deliver medication via a route other than the digestive tract. The most common routes used to deliver parenteral medications, as we said before, are through injection. However, we should also think about transdermal, which means through the skin, transmucosal, which means through the mucous membrane, topical, which means on the skin, and inhalation, which means through the respiratory tract. So, common routes by injection include intradermal, which means just under the top of the skin, subcutaneous, which means just under, getting these lectures done sometimes is very, very difficult, which is also a little deeper than intradermal, intramuscular, which is directly into a muscle, and intraarterial, which is directly into an artery. Those are not as common. Wow. So the medication is delivered into the bloodstream more rapidly than oral medications. And usually with IV, it's 100% bioavailability. Depending on absorption, subcutaneous or intramuscular can be almost as good, but maybe not 100%. Intravenous, like we said, is instantly or within seconds. Intramuscular absorption occurs within 5 to 15 minutes, depending on the drug. And subcutaneous takes several minutes. Table 32-1 gives you the advantages and disadvantages of each of these routes, or of the parenteral route of administration, so take a look at that. Parts of a syringe. Take a look at the pictures on the right. Hush, puppy. Okay, let's hold on to him for a minute and see if he shuts his mouth. So the top of the syringe where the needle screws on is the lower lock tip. It's got threads that the needle will screw directly onto if it's meant to be injected. If it's not, if it's an oral syringe, it's not going to have that lower lock. The barrel of the syringe is the long part that has the measurements on it. The plunger is the part of the syringe that gets stuck into the barrel and pushes down the medication. You show them separately here and then together. That's a 5 ml syringe. Same with here, except for this is a 3 ml syringe. The rubber stopper is what keeps the medication from sliding out of the barrel. Syringes come in all different sizes. They range from 1 ml all the way up to 60. They don't show here a 20 ml, but we do have those. And here is a tuberculin syringe, which they use for PPD, and an insulin syringe, which is used to measure insulin in units. So we talked about the barrel, the plunger, the tip, and the flange. So what you see here is a little different. This has that lower lock threading, and this one does not. That's called a slip tip. Usually oral syringes have slip tips. Some of the smaller syringes will also have a slip tip and not a lower lock. So the tip is the part of the syringe where the needle attaches. The lower lock is a threaded end which the needle can be locked on by twisting, a little safer. The flange is the flared plastic rim of the syringe used for guiding the plunger. So the flange is here. You can hold on with your fingers there. And let's see, table 32-2 has these descriptions. So needles that we are attaching to these syringes. They are available in various sizes and lengths and come in disposable and non-disposable forms. Needle selection is determined by the type of medication to be administered, the route of the administration, and the size of the patient. Disposable needles are more commonly used and are pre-packed in sterile or plastic or paper wrappers. This is usually the standard of care because they can be easily disposed of and reduce the risk of accidental needle sticks. So when we talk about a needle's gauge, we're referring to the diameter of the needle. How big around is it? We select a needle size based on how viscous the medication is, as well as what kind of area we're trying to get to on the body. Gauge sizes range from teen numbers up to the 20s. The smaller the gauge, such as 18, is larger. Okay, the larger the gauge, the smaller the diameter. So the higher you go up in the 20s, the smaller the needle. The lower you go down into the teens, the larger the needle. So if someone tells you they've got a 16 in the right arm, they have a pretty big needle sitting in that patient's arm. Now, if they tell you they've got a 22 sitting in the arm, you may be like, oh, it's a little small for that IV line. You'll get used to knowing what's common in your site. I want to say 18s or 20s are pretty common as far as IV lines go. So the length of the needle is determined by the route of the administration, the site of the injection, and the amount of adipose tissue over the injection site. IM injections require a longer needle than subcutaneous or intradermal because it's a little deeper down, whereas, of course, intradermal would be the shortest. Location also plays a role, so the bigger the muscle, the bigger the needle needed. So your deltoid up near the top of your arm is a little smaller than, say, your ventrogluteal muscle, and thus the deltoid would need a smaller needle, shorter needle. Finally, the amount of adipose tissue the patient has, such as the amount of fat in the area where the injection is being administered, will also play a role. Patients with more fat will need a longer needle than patients with less. Table 32-4 provides specific needle lengths based upon the route of administration, the location of the injection, and the size of the patient. So parts of the needle. The point is the sharpened end of the needle cut in a slanted edge called the bevel. The lumen is the bore of the hollow needle where the medication will come out. The bevel is the flat slanted edge of the needle that helps to ease the insertion of the needle into the tissue. So as you can see on picture 32-6, which I think is probably going to be somewhere. Ooh, they didn't include it in these. So 32-6 shows different needles used for various routes of administration. As you can see, the intramuscular needles are longer than the subcutaneous, which are longer than the intradermal. That butterfly needle there will be used for tubing for insertion of IV medications over a long period of time, aka starting a line. Then the safety device on the next part. Well, actually, let's finish up the hub, the hilt. The hub is the component that facilitates the attachment of the needle to the syringe. It's color-coded so you can recognize it easily based on its size, and it remains sterile when you're assembling it. You don't want to touch it. The hilt is the part of the needle in which the shaft attaches to the hub. And the safety device is the mechanism used to shield the needle. So here, once you're done drawing up your medication, you would put this on the counter and snap it onto here. That way that needle is no longer accessible and will not stick anyone. So needle safety is important. Each office should use safety devices to help prevent needle sticks from contaminated needles. There's a variety of safety devices such as retractable needles and plastic sheaths that slide over the needle. If the medical assistant is accidentally stuck, they should wash the area immediately with soap and water and report the incident to a supervisor. Sometimes there will be lab testing or a visit to the ER to determine if post-exposure prophylaxis is necessary. We're not going to get too deep into that here. Just remember, always be safe, move slowly and intentionally when using needles. So, preparing medications. In the picture on the left here, you see some different ways medications might come. For example, the ampule on the left is what fentanyl, which is a common pain medication, will come in. Oof, ouch. My puppy just hit his head. So the way an ampule works is you snap off the top by putting pressure at right about here with your thumb, and then your forefinger is connected right here. Usually I like to do this with a alcohol swab or a paper towel because these can be sharp when they break and you don't want to cut yourself. You would then use a needle to draw out, the needle attached to the syringe to draw out the liquid, and then you would use a filter needle to administer the medication. The other way you could do this is to use a filter straw to suck up the medication with the needle, and then you would put on a clean needle to administer the medication. What you see in the middle there, B, is a cartridge unit, and this comes pre-filled with the medication. All you have to do is use the cartridge device to inject it. Finally, the most common, C on the right, is a vial. Sometimes these are liquids, sometimes they're powders that need to be reconstituted. And the way they work is you just add a little pressure into the vial, and then you draw back with your syringe. And really, this is something that needs to be demonstrated in person. In a perfect world, we would all be up here in Albany and we'd be able to get together and do this, but I'm guessing you're going to get some exposure to this in your clinical practice. So, my general rule of practice for vials is to insert the needle at a 45-degree angle going in. Once I'm into that rubber stopper, which is in the middle here, you would put the needle straight up and down and then push down. Before we do anything with any of these, we always like to swab our vial with alcohol or swab our top here with alcohol to keep it sterile. So these vials can contain, ampules are always a single dose, cartridges are also always a single dose, and vials may contain single or multiple doses. Measuring medication in a syringe. The type of syringe used will be based on the amount of medication to be administered and the type of medication. So, for example, insulin gets that special syringe we've talked about a couple times now. Syringes are normally calibrated in mLs, and to draw up the correct amount of medication, the assistant must be able to properly read the calibration on the outside of the syringe. So the shorter lines on a 1 ml tuberculin syringe are measured in increments of 100th. Each small line represents 0.01 mLs, or 1/100th of a milliliter. On a 3 ml syringe, the smaller calibrations, longer lines are tenths. The longer lines are measured in tenths. Each line represents 1/10 of an ml, or 0.1 mLs. On the 3 ml syringe, the smaller calibrations are in tenths and represent 0.1 or 1/10 of an ml, and the larger lines represent half, 1, 1/2, 2, 2.5, and 3 mLs, and so on. So we talked about insulin syringes being measured in units, right? So maybe we're giving a patient 25 units of a syringe, and that's what this would look like. So there would be a mark for the halfway point, and we would draw up to that point. So withdrawing medication from a vial, and I started to talk about this earlier. When medication is stored in a vial, it can be single dose or multiple dose. So we always want to check the medication label a minimum of 3 times for the name, strength of the drug, and make sure it's still within date. We verify it against the physician's order, and we ensure the stopper is not contaminated when removing the sterile cap. Again, I generally clean the rubber stopper with an alcohol swab. So you then insert the needle, just as we talked about, 45-degree angle, moving up to a 90 once you're in. And you may need to add a little bit of air into the vial to get medication out. So they talk about that on page 904. There's an air pressure vacuum inside the vial that makes it easier to pull out, but not all vials have that. So if you need to, add your air, draw back on your syringe, and you'll get your liquid out. If too much air is inserted within the vial, the pressure will become very powerful, causing the medication to be involuntarily forced out through the stopper and out into the syringe or out all over you. So this kind of gives you a picture of an example here. They didn't start at a 45-degree angle, and the reason we do is to prevent coring, which means when you insert this bevel, there's a chance you might get a little piece of rubber stuck up into the syringe and then pushed out into the fluid, and you can actually see it floating around. So when we talked about an ampule, see how they've got their thumb on the part right there and then the forefinger on the other side. They're using gauze pads, probably soaked in a little bit of alcohol, and they break the ampule away from the body, so away from yourself, with a gauze square. So, reconstituting medications for injection. And this is the last slide we're going to cover before this will break into the next lecture part. Certain medications are packaged in powdered dry form and must be reconstituted with a liquid in order to be injected. Powder forms of medications have a longer shelf life than liquid forms, and a diluent is used to reconstitute the powder. Usually this is sterile saline or sterile water, or possibly lidocaine. The diluent may be supplied with the medication or may need to be drawn up separately. Once the diluent is removed from its original container, it's injected into the powdered drug vial, and then you gently mix by rolling the solution or swirling it. Once the particles are completely dissolved, you draw up the liquid and inject the amount that you need into a bag or as a administration IM or sub-Q.